As that's coming up, I want to, this is the last time we're together as a group here in Anaheim. So once again, I want to thank you all for making this a tremendous conference, for making this a special event, not just for those of us who have been working behind the scenes to bring it to you, but for one another. I think one of the greatest things that happens at the conference is the new friendships that are made and the old acquaintances renewed, and this weekend has been no exception to that. So this morning, I have the pleasure of introducing our closing keynote speaker. And it's difficult to put in a few short words the respect I have for Dr. Dan Furst. It's also hard for me to believe that in January, it will mark my 20th year of involvement with the scleroderma community. But it's amazing to know that Dr. Furst has been an amazing teacher and mentor to me over the course of all those years. Dan and his wife, Elaine, have devoted their adult lives to the scleroderma community, Elaine serving as chair of the Foundation's National Board of Directors for many years, and Dr. Furst being an immediate past president of the Scleroderma Foundation's Southern California chapter. They both have given me a tremendous education, not only related to this disease, but to the world of science, which is not my background. And Dan has always been the person who I can turn to for great advice, help, and encouragement. And I will always cherish that friendship that we've had and that collegial relationship we've had. He's recognized internationally as one of the foremost researchers and clinicians in scleroderma, as most of you know. And he is the Carl M. Pearson Professor of Medicine at the University of California, Los Angeles Medical Center. He's a driving force behind the Systemic Sclerosis World Congress held every 2 years, most recently this past February in Rome, where 1,195 researchers from 53 countries around the world were in attendance. With a name and reputation that is synonymous with scleroderma clinical care and research, he hardly needs more introduction from me. So please join me in welcoming my great mentor and teacher and esteemed friend, Dr. Daniel Furst.
That was really nice, thank you. And my mother would have loved it too. So this morning, thank you all for coming. It is not exactly the usual time on Sunday morning for most of us to get up. So thank you for doing that. What I want to do this morning is I want to talk to you about some of the exciting things that are happening or happened in the last year. There are a couple of items just right here about the title itself. First of all, there are many, many different articles and studies. I had to make some choices. I'm sure I left some out. Second, I want to point out that the word research has been emphasized. Research means redoing things, and that's what we need to do. A single study in one thing does not answer the questions, and we'll talk about some of that as we go on. I have disclosures. I work with many different companies to do my research, and you should be aware of that. And actually, I'm pretty grateful to that. Otherwise, I couldn't do this stuff. So, 25 years ago, patients with scleroderma really had few options. Since then, patients have had improved their outlook. Many have done extremely well, and things are looking up for scleroderma patients. We've got to keep that in mind. And it's in that context that I'm going to look at some of the new stuff that's come to mind. There are now conferences devoted to scleroderma, such as our World Scleroderma Conference. It has 900. I just found out it was 1,200. Okay, good. People and presentations. And we're going to do research and talk about research with redoing of findings and careful, controlled studies. What I'm going to talk about are these. One, diagnoses is a new definition of scleroderma that's now available and will make a significant difference, I believe. We're going to talk about understanding some of the genes in scleroderma and what the gene signatures are and what that may mean for us. We're going to talk about some aspects of treatment. And we're going to talk about some aspects of new clinical things going on, particularly in the GI tract and in arthritis. First, let's talk about a new definition of systemic sclerosis. And here it is. It's a classification we just put out last year. And what it does is it quantitates the things we've already been doing. So, for example, having skin involvement proximal to these joints up here gives you a score of 9. And all you need is 9 to be defined as having scleroderma. But it also gives certain numbers of points to puffy fingers or Raynaud's or telangiectasia, those little red dots some of us get, and antibodies. And if you add all those up and it comes up to 9, that's the definition. So why is that something different? Well, first of all, doing that has improved what's called the sensitivity and specificity of the diagnosis. You'll see the number 0.8 for 1980 definition, the previous one, and 0.95 for our present one. Sensitivity is how sure we are that no one with the diagnosis is missed. So we may have too many people, some people who don't have the diagnosis, but at least no one was missed. And you can see that the sensitivity is much higher for the new definition, right? And then the other aspect of it is the specificity. How sure are we that everyone that we've identified as having scleroderma really has the diagnosis? Two aspects of the same thing. And you can see that it's very high for the new definition. So it really means that if we make the diagnosis earlier, then treatment can be started earlier. And this means that we may, hopefully will, in the future be able to prevent some of the damage that occurs. In fact, I'm working with my colleagues in Italy right now, and we're going to try a study to see if we can prevent people from developing scleroderma. And it's based on things like this. So this is a really major step forward. Next, let's understand the disease a little bit better. The importance of genes and the fact that early and late scleroderma is associated with different proteins which will hint at different treatments. It's based on this idea. That is, there's a genetic susceptibility that can affect the immune system and the vascular system. And on the background of some things going on in the environment, they can be activated and go back and forth, each activating the other, resulting in fibroblast proliferation. Fibroblasts are those cells that kind of support us, but they do more. They produce collagen, and collagen is scleroderma. And that collagen then goes on to cause immune activation, and you get this cycle that we try and break. And we're going to talk first about this aspect, the genetic susceptibility. But a little short side trip to understand immunity, because we're going to be talking about immunity a great deal. And it depends on immune activation and this, whack-a-mole. I don't know how many of you ever played whack-a-mole, but basically, there's these little moles that pop up sort of all over the place, and your job is to knock it down. And that's us. The immune system getting out of control, and we're trying to knock it down. And so you see this, right? People knocking it down. But what's interesting about this is that there are lots of whack-a-moles. Everybody's got a different whack-a-mole. It looks pretty simple, but if you turn it over, it gets a little more complicated, doesn't it? So what we see as immunity at the surface is pretty straightforward. Prevent us from getting infections, etc. But you turn it upside down, it's a little more complicated. So how does that apply to us? That's the immune system. Now, there will be a test, so please remember all this. Okay? But what it says is it's just like whack-a-mole. And what it is in a simplified form is that the immune system is dependent upon cells in the body that activate other cells, some of which are called T lymphocytes, other B lymphocytes, and those turn on other cells that produce proteins that cause the inflammation. So if you think of immunity as a whack-a-mole, you'll get a good handle on immunity. So now let's get back to genetic susceptibility. So this is a gene. It's part of a chromosome. It just happens to be chromosome 6. And on that chromosome, in each area are these little genes, each one of those little marks down below, and each of those produce proteins. And the proteins are what make our bodies work. So the genes produce the proteins that cause our bodies to work well or not so well. So let's talk about that a little bit. We already know there are a fair number of susceptibility genes in scleroderma. So there's a gene, and these names don't really matter, but called PTPN22, which is typical for RA patients. And there's a gene called STAT3 associated with fibrosis that is also associated with scleroderma and RA and lupus and polymyositis. And there's a gene associated with scleroderma, TNFI, P1, etc., that is not only associated with scleroderma, but also RA and psoriasis. So we know that there are genes of susceptibility for scleroderma, and it also points out that scleroderma is part of the spectrum of autoimmune disease. And we have now found, through Dr. Asasi, some of you may have heard him give a talk yesterday on tendons. This is his work. That there are genes associated with B cell activation. Remember I mentioned the B lymphocyte? And there are cells that are genes associated with T cells, another one of those things in immunity. And there is a part of our immune system that is very, very early called the innate immune system. That's all the way back. One-celled animals have this, etc. And those are part of the immune system that is primitive but very important for fighting bacteria and viruses. And there are two genes associated specifically with scleroderma, associated with that very primitive immune system. And then he also found a gene that's associated with blood vessels, a very important part of scleroderma. So you see, we've begun to find genes associated with various aspects of the immune system. Not only that, we're getting specific. We've now found genes that are associated specifically in scleroderma with pulmonary arterial hypertension and with interstitial lung disease and even with renal crisis. This is pretty cool because if we understand those genes and remember the proteins that they develop, if we understand those proteins, we may be able to go back and say, wait, what do we need to do to interrupt an abnormal protein? And thus, we will be able to treat better. So this genetic background that we're beginning to understand is truly important. And it's one step at a time, a little bit each year, but we're beginning to get there. And there's even more. We've been talking about individual genes, but in fact, you can look at multiple genes. These are called gene signatures. And what you see on this picture is, at the top, all the columns are different, got to get this straight, different patients. So the columns are different patients, and the rows are different genes. And so you can see that certain groups of patients have that red, that's genes turned on. The green, by the way, is genes turned off, and the black is genes that are inactive. You can see that there are certain genes that cluster for certain patients. And many of those genes in the top group have to do with inflammation. So there are gene signatures for individual patients associated with inflammation. What does that mean? Well, it means that those folks have more inflammation. And consequently, ultimately, we should be able to say, look, you come in, we'll get a little blood, we'll look at your genes, and if they show a lot of inflammation, we treat that. And then, in this particular set of genes, there's a group that are called proliferative. You can see the red ones over in that one section. And patients who have that have a proliferative signature, which means we treat them differently. And then there are those with, for the moment, are normal-like. So genes and gene signatures are going to lead us to individualize therapy for individual patients. So we're not going to have to throw a bunch of drugs at each person. We're going to be able to tailor those drugs. And so this is the first step of getting to that. And in fact, there is a drug similar to drugs that's being used now. It's called Gleevec. Gleevec is used for certain kinds of lymphomas and has been used in scleroderma. And there's a cousin of that that's much more potent called nilotinib. And what was done, this nilotinib was given to some patients with scleroderma, and then the skin biopsy was done, and the genes examined before and after treatment. And what you can see that in patients who improved, their red turned green. Overactivity to suppression of those genes. So this drug affects that signature of genes. So you're seeing now the beginnings of actually finding drugs that affect certain genes. And so if we did this study, and if the research on this drug ended up showing it worked, we could have a patient come in, do a skin biopsy, we look at her genes, and give her nilotinib if the genes looked in one particular way. So we're actually getting to the point of beginning to treat this way. I think that's super. Research, remember, early on, but we've got a place to go. Now, when you look at our diagram, there are certain proteins that are developed by the immune system that can affect various aspects of the way the disease occurs. One substance is called tumor necrosis factor. Produced by the immune system, turns on the vascular system. Another protein called interferon gamma is used by fibroblasts to produce collagen. I am going somewhere with this. And what we found is that patients at different times in their disease have more of one, and at another time, more of the other. In this particular study, notice only 40 patients. There were a group of a group of patients with late disease, the green column, that produced more interferon, that protein on the right. This protein that you see over, if I can get this thing to work. Well, let's pretend you can see this. the interferon gamma signature. And you see over here that patients with late disease produce more of the interferon gamma than those with early disease. And in the opposite way, patients with early disease tend to produce more of the TNF. So different proteins produced by the same patient at different times in their disease course. Again, what does that tell us? It tells us that we need to treat patients differently at different times, and it's beginning to tell us which way to treat them. So what we've done is we've looked at the importance of genes, possibly leading to personalized treatment in the future. And we've started looking at the differences in patients over time and how their disease changes, consequently requiring different therapies over time. So what about treatment? I'm going to go back to this, and we're going to look at treatment of ulcers, and we're going to look at treatment of the immune system with 4 different products. A goat immunoglobulin, I'll get on to that, rituximab, of which you've heard, some of the newest data you've probably heard also about stem cells, and something about TNF. Remember that substance we just talked about? This is an ulcer. Those of you with scleroderma know both how much Raynaud's can hurt and how much this kind of a change can hurt. A lot of my patients, I give, big league drugs, morphine, Dilaudid. This really hurts. And here's an open label study. Now careful, it's open label. It may appear better than it is because there's no control. But in this open label, looking at ambrisentan, that's a drug used for pulmonary hypertension. I always get these names wrong, but I think it's Letairis. And there are 20 patients, and you can see that over about 24 weeks, their ulcers decreased by an average of 4.5 to 1 over 6 months. Now, think to yourselves, those of you who have had ulcers, where the weakness of this study is. Using only heat, cleanliness, and tincture of thyme, most ulcers heal by 6 months. Consequently, how do we know it was a drug? That's why we need the controlled study here. But it is the first step. And there was another drug in the same area, bosentan, Tracleer, in which a similar thing was done, where you see that 70% of the patients improved over a 13-month period in people with very resistant ulcers. So it may help. By the way, you never get something for nothing, right? There's some liver side effects you can see there. But it may help. However, this is not a controlled study. We need to do research. And then a study of Viagra. Now, many of you are using Viagra for the ulcers, but really, you have to be careful in these studies. There was no control in most of the studies for Raynaud's in using the sildenafil. And what you see here, that most of these people had tried another drug. Look at the huge number of patients, 17. So be a little careful there too, right? And the first drug didn't work, and so they used sildenafil, and notice the dose. For pulmonary hypertension, the dose is 60. Here we're talking 150. I have used 300. Okay? This is high dose. But if you look at it, you see that complete response, that light blue, for those of you who are not colorblind, was effective in 50% of the patients. So what we've got are open studies of ambrisentan, bosentan, sildenafil, okay, which seemed to show possibility of response, as well as other drugs, tadalafil and macitentan, showing roughly the same, in open studies that indicate that sometimes we can use these drugs. Now, there are a lot of problems, right? One minor problem is that bosentan costs a mere $75,000 a year. I can get 2 cars for that, okay? But sometimes this is available when it's necessary. So there are treatments available for ulcers, but there are more treatments needed, and these are some of the early data looking at some of the new ways we're doing these. Okay? Now let's get to some of the immune activation, immune therapies. The first is hyperimmune goat serum. See that little goat? Thank you, Elaine. Where are you? What it is these immunoglobulins are proteins. It's a mix of proteins. And there are patients of mine who use this intravenously in very high amounts to treat some of the diseases. This case, it's a placebo-controlled trial. That's fantastic. It's controlled, and it uses hyperimmune serum, which is a small amount. It's just a shot into the muscle. There were only 10 patients per group, and it was a 26-week study. And if you can look at this, the number of patients whose skin improved by a reasonable amount, 5 units or more, was 50% in the treatment group, compared to 1% in the placebo group. That's pretty good. The numbers are too small to be statistical, but this is pretty hopeful stuff. And I think it's enough to want to do research. The good and the bad, not so much the ugly. The good about the goat immunoglobulins, a controlled trial. It's given as a shot, and it requires a small amount of protein, so it's tolerable. It wasn't significant, and the numbers are small. And then goats, come on. I know, they're so cute, you know. On to rituximab. Now, many of you already may be on rituximab, but you need to be careful. You saw some of the work on PAH with rituximab yesterday. And if you look carefully, you'll have seen that there aren't controlled trials. So here is one of the trials of rituximab, and it was published in 2012. And what you can see is that the skin score, MRSS, dropped from 13 to 7, indicating a real change. 4 or 5 points is a real change. The pulmonary tests, the forced vital capacity, how well you move air in and out, and the diffusion capacity, how efficient you are at getting oxygen out of the air, were stable. That's probably not bad. Not controlled, remember that, but they did something else. In this trial, they used controls, which are not the best way, but they used controls, patients who were not given the drug. But there's a selection bias here, that's what we call it, where the people who got the rituximab were thought to be the ones who would respond. And the ones who did not were not thought to respond, and consequently, you don't know. But what was interesting, and I think this is the important part of this trial, is on the right, you see that column going down that showed a 38% decrease in the collagen in the skin. So this is a biologic effect that's very real, okay? Compared to control, where there was really 5% change. So that's pretty hopeful. And in the 4 patients who took the drug, the B cells, which is what was affected by the rituximab, decreased and their skin improved. In the 12 patients where the B cells did not decrease, the skin didn't improve. Again, a biologic correlation. It looks like the drug is doing something and it correlates with a clinical response. We still need to do the research, but it's getting there. And those studies are, in fact, ongoing. Lots of open experience, kind of like CellCept. Lots of open experience. We're doing the study for CellCept as well, but until the research is done, it's not been shown to be effective. And there's a danger of assuming it works rather than proving it. Now, why are they being used in scleroderma? Because we need something for some of the folks who have it. So we do it, but we need to be careful about what it means. Now let's talk about stem cells. There are 2 stem cell trials, one in the US called SCOT. We're doing that with a bunch of other centers. And it uses more immunosuppression than the group called ASTIS. That's a European trial. Now, this is kind of fun. A friend of mine and I were sitting in a bar in Innsbruck, honest to God. And we sat down and said, you know, we should do this. And this is the outline of both ASTIS and SCOT. That was in 1995. And now we're getting the results. It's kind of cool. He's a European, I'm an American, we got the whole thing. And the beer was good, too. So here's the result. If you look at this carefully, what this looks at is what's called event-free survival. That means you don't need oxygen, you don't need total parenteral nutrition, you don't need dialysis, you didn't die. That's called event-free survival. Okay? And you can see that the patients who had the transplant, the red line, for those of you who are colorblind, the top line, at the end of the period, there's less new events. Events-free survival was higher in the red line, the transplant line, than the blue line, the high-dose cyclophosphamide line. And it's statistical. This was just published. It shows that it works. Now, you look at this in some detail. Look early on in the first year. What do you see in the first year? You see that the red line, the transplant line, had more trouble early on. So transplant's dangerous stuff. And that's reflected in the beginning part of this. But over the longer haul, it looks like transplant works. Now, you never get something for nothing, so here's this part of it. There was an 8% death rate in the transplant group and a 4% death rate in the high-dose Cytoxan group. Okay? So transplant is not for everybody. Transplant is for that 10 or 15% of patients who we can tell are going to do really badly. So don't go to your doctor and say, I want transplant. You got a 10% chance of dying. Okay? Now, this is being reproduced in SCOT, in the US, so the research will show whether or not it works. We certainly hope it does. ASTIS, the trial you just saw, is a controlled trial done right. I'm on the overview committee for this, and I made damn sure it did. And it was rigorous and transparent. It's only for the most severe, and we need to wait for the SCOT trial results. What about TNF? TNF-I, TNF inhibitors, there are 5 of them now for treating rheumatoid arthritis. Okay? So it's available. Is it being used in scleroderma? Well, this is a look at a survey of 79 European centers, 3,000 patients. 2% had used a TNF-I, and they'd used it for polyarthritis, 60% of the people, and for inflammation, and in controlled trials. And did it seem to work in these open trials? Yes. So this is ready for controlled trials. It's very hopeful. So what we've done is we've talked about some of the treatments. Now let's talk a little bit about the clinical aspects of scleroderma. The GI tract, gastrointestinal, GI, a little bit about pregnancy and arthritis. This is a study out of Egypt. And what they saw was in a group of patients not selected for GI problems, that 85% of them had some upper GI symptoms like heartburn and things like that. 75% had lower ones, bloating, things of that sort. And some of them were pretty severe. Now, this is Egypt. They don't have as good care, etc., so it's a little bit more severe than you might expect here. But it says that there are a lot of patients who have GI problems. And those of you with scleroderma don't need me to show you this slide. What's interesting is that we live with a huge number of bacteria. We live with 100 times more bacteria than we have cells. Okay? They're doing something in our GI tract, so let's find out about them. Most of the time, there are 500 species of these that live in our gut, in our colon. All sorts. And they live together happily, like this picture by Van Gogh. But when they get messed up, it looks like this. What it looks like is if you look at the numbers, in the colon, there are trillions of cells, 10 to the 11th. And there's very little in the small bowel. You can see 100 per cc, 10 to the first. Well, it's 10, actually. When you have scleroderma, those bugs go north and into the small bowel. And the result of that are things like bloating and gassiness, nausea, vomiting, diarrhea, even heartburn can be associated with this. So what can we do about it? Well, we can treat them. This is for a drug called rifaximin. Pretty hard to get, but pretty darn good. Doesn't get absorbed, does a good job. And if you give it, it improves the patient's feelings 75% of the time compared to placebo. Okay? So treating the bacterial overgrowth is important. You got to find it, you got to prove it, you got to do tests for it, but if you have it, treating it can be very effective. And it does more. If you have GI symptoms and pain and itching, that's associated with poor sleep, and you can see that in the graph, where 19% have GI symptoms, 20% have pain, 13% have itching, and all of those contribute to poor sleep. So GI problems, as well as the other things you know, contribute to sleep. So now, not only do you have gas and pain and diarrhea, but you can't sleep. Great combination. And more than that, this is a picture of a lung with some scarring in it. And you can see the white areas are scarring, and there's sort of blebs inside that we call honeycombing that can occur in scleroderma. And it turns out that if there are esophageal abnormalities, and you can see on the left varying stages of esophageal abnormalities. The most important one is stage 4, where you can see it's poor muscle movement with low tone at the bottom. That's stage 4 and successively less. And if you look at the table, you can see that interstitial lung disease is found in 45% of the patients with stage 4 esophageal abnormalities. A correlation between what's going on in the stomach and the lungs. And this has been shown multiple times now. And there's been one other thing that I think probably is the most important thing in years in the GI tract, and that is a development of a model for the GI tract in scleroderma called the TGF-BR2 model. All right, whatever, but it's a model. Okay? And what it shows, you can see it on the right, that the GI tract in mice with this looks like the GI tract in scleroderma patients. The fibrosis at the bottom, those little areas of broadened white stuff, and the upper part where the GI villi, the things that absorb food, are less. And it's associated with collagen in that same area. So it looks like the GI tract, and the collagen is like the GI tract. And even more than that, if you look at the way the muscles work, look at the wild type, WT, and the carbachol, that's just something that makes the muscles work. You can see that at the bottom, in the wild type normal, you see a lot of squiggles. That's the muscles working. In the mouse model, you see the muscles aren't working. So it looks like the GI tract in scleroderma patients. That means that if we have the model, we can test the model, we can find out what's going on, and we can treat, and then we can transfer that to humans. A major step forward, truly. One slide about pregnancy. I think this is very reassuring. This looks at a group of normals, 100 scleroderma patients, 109 pregnancies compared to normals. And what you see is that there's more preterm delivery, more early delivery, and more low birth weight. What you don't see is fetal death. Consequently, it's not a normal pregnancy, but patients with scleroderma can carry their babies to term. You have to watch more carefully, but it means that people can get scleroderma and yet have babies. There are other issues, of course, but at least they can have the babies. And let's finish up with talking about joint pain. This is a joint, and you can see there's the bone. There it is. There's the bone, there's the lining, there's the synovium, or the active parts of the joint. And patients with scleroderma can get anything, anywhere. They can get slight stiffness, they can get acute problems, building up problems, a few joints, many joints. It can be in the fingers, wrists, ankles, anywhere. So you can get this anywhere. Now, when you look at a rheumatoid arthritis patient, you can see the swollen joints. You see where those arrows are. So I can tell that a rheumatoid arthritis patient has swollen joints. Look at a scleroderma patient. Can't tell so easily, can you? So it's very hard to tell whether patients with scleroderma actually have arthritis or not. And ultrasound of the hand has made the big difference here. Okay? And you can see here in the upper left that orange and red part is the blood flow in patients with inflammation of the joints. And that isn't there if there's not arthritis. So you don't have to see it, you can actually examine it. And on the bottom you can see, it's a little harder to tell where the arrows are, that's where the tendons have become inflamed. And what was found that although about 30% of the patients had synovitis on exam, 45% of them had it on ultrasound. And whereas about 15% had it on exam, 27% of them had it on ultrasound. And of course, there was calcinosis as well. So ultrasound is a much more sensitive way to tell if there's arthritis. Now, if we can prove there's arthritis, then we can treat it. Okay? If there's unsuspected inflammation, then treatment can be started and can lead to less pain and hopefully less disability. So what we've done, we've talked about diagnosis, we've talked about genes, we've talked about treatments, and we've talked about advances in clinical aspects of scleroderma. Thank you very much. Now, we do have a little time for some questions. The question is, what's the difference between early and late scleroderma? There's no absolute cutoff, but in general, we think of early scleroderma as 2 years or less, and late, quote unquote, as more than 2 years. Okay. So the question is, what's the difference between taking a look at X-rays and ultrasound of the hands in arthritis? Well, X-rays give you what I call a static view. It'll tell you sometimes a little bit about whether there's swelling, and it'll tell you a lot about damage to the bones. What it won't tell you about is whether there's inflammation. So ultrasound gives you inflammation, X-rays do not. So how far away are we from using gene signatures as a diagnostic tool? A long way. Okay? I'm talking 5, 6 years. Okay? But it's beginning. It's really kind of nice. The last slide was to remind you, don't buy snake oil, which is a guaranteed cure for everything. All right, back to the questions. Thank you. So the question was, has the protocol changed over time? That's actually a very important question and a very tricky one. Because if you change the protocol and you change the kind of patients that get into a protocol, that might change the apparent results. And so what was done in the European protocol is they accepted patients with less severe disease later on. Still severe, but less severe. And in the Scott protocol, we combined some of the measures to get a single measure. Okay? And we're going to have to go back and look at the effect that made. So that's a good question. So the question is there I mentioned a drug that's being used for the GI tract. Is that known in general by the GI docs? The drug is called rifaximin, or Xifaxan, I think is the trade name, and it's available, and it is really hard to get because the insurance companies don't like it. Frequently, what happens specifically is we do a lactulose breath test. That's the kind of test you have to do to look at bacterial overgrowth. And if it's there, then you try and treat with a more standard drug. Sometimes something as simple as Keflex works, or doxycycline. And then if that doesn't work, we try and use rifaximin. Okay? And as it said there, 75% of the time it works. Okay. So the question is, what about using different surgeries than for the GI tract? This particular surgery is a bypass surgery called Roux-en-Y. In fact, Roux-en-Y is not a treatment for the GI tract and scleroderma. It's a treatment to decrease weight. It kind of bypasses some of the way we deal with the drug. So Roux-en-Y actually is not something that would be used for scleroderma per se. Now, are there surgeries that are used for the GI tract? Well, yes, there are. One of the things I use a fair amount is called a gastric pacemaker. It gets the GI tract muscles to work when they just won't work any other way. Another one is something called a rectal stimulator for patients whose lower GI tract, anus and rectum, just doesn't hold, so they have constant soilage. And that also probably works. Double-blind studies, not so much. In some patients who just can't get food in, we use total parenteral nutrition for a period of time. We use tubes into the stomach to get food in that way. But, hopefully, very few of you will need that. So the question is the FDA rules, et cetera, is it holding back the research here compared to Europe? The answer is probably not. In some areas, they are much more liberal. And in some areas, the FDA is beginning to deal with a different way of approaching it that turns out to be actually more liberal than the Europeans. In most of the rest of the world, they depend on the European or the American regulatory, and they'll say, if it passes there, we'll buy it. Okay. The question is, when and how do you decide when a patient should have a stem cell? Good question. Turns out, when a patient walks into the room to me the very first time, if she has early disease, less than 2 years, and her skin score is very high, and she has tendon friction rubs, and if she has anything going on in her lungs, she probably is a candidate. So I can tell most of the time when a patient first walks in the room. Now, look, 10% mortality. You don't do that without trying something else. So even in the worst patients, you have a little time to try something else before you do that. But those of us who are in centers, and most of the people talking here at the last 2 days have been from centers, will be able to tell right as soon as the patient walks in. So thank you very much for your time, and let's move on.